Hello everyone, I am Aditya G Rao, Assistant Professor, Department of Medical Imaging Technology, Yenepoya School of Allied Health Sciences. So today I will be discussing on the topic CT coronary angiogram. So at the end of this session, you will be able to enumerate the indications, contraindications and patient preparation for CT coronary angiogram. We will be able to describe the scanning protocol for the image acquisition and describe the post-processing techniques involved in CT coronary angiogram. So what is CT coronary angiogram? So with a significant increase in the number of cardiac arrests in the current time, which is often linked to coronary artery disease, CT coronary angiogram plays a vital role in ruling out coronary obstructions, plaques or anomalies that could be possibly contribute to the medical emergencies. So what is coronary angiogram? So coronary angiogram is a non-invasive procedure in which we inject the contrast media to the blood vessels and we visualize the blood vessels of the heart. So this study will have the ability to image the cardiac function, perfusion, myocardial morphology and coronary arteries in a single acquisition. So we shall go and see the vessels of the coronary, vessels of the heart now. So right and left coronary arteries arise from the aortic sinus. So furthermore, the right coronary artery divides into posterior descending artery, conus branches and marginal arteries, and left main coronary artery divides into left circumflex artery and left anterior descending artery. So the left circumflex artery here divides into obtuse marginal branches and the left anterior descending artery divides into diagonal branches. So what are the indications? So we do CT coronary angiogram in case of angina, shortness of breath, post myocardial infarction, post percutaneous coronary intervention and symptomatic coronary artery disease. And we do not do this case in case of severe COPD or asthma or second or third degree heart block or in case of hypotension. So before going ahead with the procedure, there are a particular pre-medication which has to be taken. So to minimize the motion of the heart during imaging, we may have to ask the patient to take medications to lower the heart rate prior to the procedure. So these are commonly prescribed medications such as beta blockers. Along with this, we may also ask the patient to take nitroglycerin just prior to the scanning to make sure the arteries are more visible, as this medication will dilate the vessels. Other than that, there are a couple of patient preparation which we have to take care of. One is NPO, the patient should be fasting 4 hours before the procedure. He shouldn't take anything from his mouth. And heart rate check. A heart rate of 60 to 70 beats per minute is optimal for angiograph. If the patient has heart rate which is too high, beta blockers may be administered to reduce it. Other than that, we shouldn't ask the patient to walk or we shouldn't ask the patient to consume caffeine before the test, as this may lead to increase in the heart rate. And also all the radioepoch objects should be removed from the region of interest. We have to also instruct the patient before the patient is scanned. So this usually when the patient is put on the gantry or the table, the patient will get anxious because of the machine. So we should instruct the patient properly so that the patient doesn't move or his heart rate doesn't increase in between the scan. Also, one important thing which we have to see is the gating. So the electrode should be placed properly in the 4 regions, namely RA, LA, LL and RL. So RA electrodes has to be placed below the clavicle on the right side, LA electrodes has to be placed below the clavicle on the left side, and then LL electrodes has to be placed on the lower left abdomen and RL electrodes has to be placed on the lower right abdomen. Once this is done, we'll move ahead for the positioning of the patient. So the patient will be supinated on the table with the feet towards the gantry and his arm should be over the shoulder in the comfortable position. We can ask the patient if he requires pillows or blankets so that the patient is comfortable and he doesn't move in between the scan. The acquisition of the dataset consists of 2 major steps. One is calcium scoring and the other one is CT coronary angiogram scan. Let's go and see calcium scoring. So coronary calcium is a product of systemic atherosclerosis which is responsible for coronary artery disease. So if the deposition of the calcium is present in the blood vessel, that may lead to CAD. So there are three methods in which we can score the calcium in the blood vessels. One is calcium volume, calcium mass and Agatston score. So we will be seeing the Agatston score now, which is widely followed worldwide. So for this we have to scan the patient. So we will be keeping the FOV will be selected from the carina of the trachea, and then we will cover it till the diaphragm, and then we will make sure that the heart is covered for the imaging, and then we take a single acquisition where the heart is imaged. So now if you see, there are multiple images in which the calcium deposition is placed. These are case by case images. In case 1, if you see, there is the artery here which doesn't have any deposition of calcium. So this means that the calcium score is somewhere around 0. That is no evidence of calcium. If you see in the second image, there is a high density image, which is a high density structure which is formed, which is nothing but a calcium deposition. So the CAC score is around 29 in this case. There is slightly more deposited calcium in this blood vessels, so the calcium score in this case was 250. And then in the next case, which we are seeing right now, the amount of calcium is a lot, which is why the score is around 1200. So a calcium score of 0 shows that there is no evidence of calcium. If the calcium score is around 1 to 10, it means that the minimum amount of calcium is deposited in the blood vessel. If the calcium score is 11 to 100, that means that there is mild evidence of calcium in the blood vessels. If the score is around 101 to 400, that means that there is moderate evidence of calcium in the blood vessel. And if the score is around more than 400, that means that there is extensive evidence of calcium. In case of more than 400 of calcium deposition in the blood vessels, we do not go ahead with the calcium as CT coronary angiography. The next step is nothing but the CT coronary angiogram study. So once the calcium scoring is done, and if the evidence of calcium is lesser than 400, we plan for CT coronary angiogram. The planning will remain the same. So we slightly cover slightly above the carina of the trachea to the diaphragm, and we make sure that the entire heart is covered for imaging. Once we do that, we keep the locator. The locator will be placed in the carina of the trachea. So once this locator is placed, we take a scan and then we get the axial slice of the selected locator. So in this axial slice, we mark the tracker. So we keep the tracker in the descending aorta somewhere here, okay, and then we'll go ahead with the injection of contrast media. So what is the contrast media that we use? So we use non-ionic iodinated contrast media, which will be injected intravenously with the help of the pressure injector, and we give it at the flow rate of 5 to 6 ml per second. Let's go to the scanning protocol. So the patient will be supinated on the table, and the start location of the scan will be the sternal notch, and the end location of the scan will be the diaphragm. So we select the minimum thickness of the slice, that is around 0.66 mm, and the increment which will be selected is overlap, and the temporal resolution of 210 to 165 will be selected. And for all this protocol, the scan time that would take to image the whole heart will be around 6 to 12 seconds. And then we give the contrast media up to 60 to 80 ml with a flow rate of 5 to 6 ml per second, and the threshold which will be selected will be 150, and the post threshold delay will be non-timed. So we do not keep any delays after once the contrast is being tracked. So the KVP which we give is around 120 KVP, and MAS will be 850, and the locator and the tracker will be kept at the ascending aorta. There are two main techniques of imaging, that is prospective gating and the retrospective gating. So we'll see one by one. So prospective gating, in this method, the CT scan is triggered to acquire the images only during a specific phase of the heart cycle. Typically, the scan is performed during diastole, when the heart is more relaxed and the motion will be minimal, so that we can image the heart in a very proper way, and the image quality will be good. The scanner advances the table to the prescribed starting position and waits for the arrival of the predetermined cardiac phase, and then we wait and we acquire the image. So that is why this method is also called as step and shoot method. So if you see the graph here, so when the diastole phase is there, where the image is, where the moment is slightly lesser, we take the scan. One advantage of this method is that the radiation dose is typically less when we compare it with the retrospective method. Now let's see what is retrospective gating. In retrospective gating, the scanner will continuously acquire the data in the spiral mode with the table traveling at the contrast speed. So images are reconstructed from the specific phases of the cardiac cycle afterwards, and this capability can be used to identify the cardiac phase with the minimal motion and less artifacts, making it better for the patients with the irregular heart rates. So when we compare it with prospective gating, one advantage of retrospective is that we will be continuously acquiring the images. So for some of the arteries, if it is not visible in one of the phases, we can reconstruct it in the other phase where the heart movement is pretty much low or the motion is less. If we feel like that, we can reconstruct it in another phase, and then we can produce the images with that phase. So that is one advantage, but the disadvantage of this one is because the acquisition will be done continuously, the radiation dose to the patient will be increased compared to the prospective gating. Okay, now let's move on to the post-processing. So the post-processing of the CT coronary angiogram is a complex component of the CT coronary angiogram study. So the techniques which will be involved in this are calcium scoring, multiplanar reconstruction, curved planar reconstruction, volume rendering, and maximum intensity projection. So we go and select the study, and once the study is selected, we go to something called as calcium scoring first. So we have to analyze the amount of calcium. So this post-processing technique will be done before CT coronary angiogram study. Alright. So once the calcium scoring is done, we go to this post-processing technique where we will select the acquired data set. So in this acquired data set, which is not reconned, we open the application, and then we mark or we seed the amount of calcium. Once the amount of calcium is seeded, so we seed all the calcium depositions, and once it is seeded, we get to know the total score of this. So based on this score, we see if we have to go ahead with the CT coronary angiogram or we have to cancel the CT coronary angiogram. So this is the simple post-processing technique that is involved in calcium scoring. Once this is done, and if we are going ahead with the CT coronary angiogram, the scan will be done, and then we will recon it. So we will be reconning it in the multiple phases. So once the recon is done, we open the application where the cardiac or the coronary angiography post-processing is done. So with the advanced software and AI integration, the vessels will be segmented automatically, and we have to verify the same. But until that technology becomes highly efficient, we may have to track the vessels manually. So what we do is, so we will be tracking each and every vessel, and then we will be producing the curved image of it and the straight line of it. So if you see, so these are the vessels which is being tracked one by one, and once we track everything from here to the end of the vessel, we get the straight line and the curved line of the vessel. So if you see this, so this will be the center line of the vessel which is filled with the contrast. So we should start from this, and we should continue to track this vessel until the contrast filled vessel is seen. So once we do this, what happens is we will get turn image like this. So this is nothing but the curved image or the curved reconstructed image of the particular vessel. In this case, it is right coronary artery. So like this, we have to do the post processing for each and every vessel which is being seen in the CT coronary angiography study. So similar will be done for LAD, similar will be done for left circumflex artery, similar will be done for acute marginal or diagonal branches or everything. Alright. So once this is done, this will be the curved reconstructed image. Along with this, we have to send the straight line of this as well. Once all the vessels has been tracked, we will be sending the VR images of the whole heart along with the coronary vessels. Along with that, we will be sending the tree view of the coronary vessels. So this is how the reconstruction will be done. So to summarize the whole thing, CT angiography or a coronary angiography is a valuable tool in diagnosis and assessing the coronary artery disease with a non-invasive approach, offering both convenience and precision for the appropriate patients. So what do we do in this? We inject the contrast medium to the bloodstream, and the CT scanner will take multiple images to generate the three-dimensional images of the coronary arteries. So what happens is the dye will help to highlight the blood vessels, making it visible on the scan. And once the scan is done, we will be doing the post-processing and tracking each and every vessel which is seen in the CT coronary angiography. So once this is done, the CT angiography procedure will be done and the radiologist will report the scan. So these were the few of the references from which the presentation was made. So thank you so much. If you have any doubts or any clarifications, you can mail it to adityagirao@yenepoya.edu.in. Thank you so much.